Welcome everyone. Just to say that we will give a couple of minutes for people to get logged in, and we will start in a few minutes. Thank you. All right, I think we're ready to start. Welcome everybody once again. I am delighted to be here and see so many people joining us from online across countries and time zones for the launch of the Thinking, Working Politically Community of Practice Global Webinar Series, which we are actually kicking off today with what promises to be a fascinating discussion on the resilience of health systems in different countries in the context of the COVID-19 pandemic. My name is Alina Rocha Menocal, and I am the director of the TWP Community of Practice hosted at the University of Birmingham, and I'm also a principal research fellow in politics and governance at ODI, which some of you may know as a leading think tank on global affairs. For those of you who may be less familiar with the community of practice, let me just tell you a little bit about who we are. In essence, we are a diverse and growing global network of practitioners and researchers in development and global affairs who are committed to promoting more effective development policy and practice. Our network includes all sorts of people with extensive experience working in or with the research community, civil society, organizations, donor agencies, and implementing partners. With this webinar series that we are launching today, in collaboration with different partners and with support from the UK's Foreign Commonwealth and Development Office, we want to convene conversations that address leading questions and debates related to thinking and working politically. We have a very exciting lineup of events coming up, including on localizing development and what that entails, and also on the question of how support to democracy can be made more politically smart and more effective. So please do take a look at our website for more information and for updates. And also make sure you sign up to our newsletter if you haven't already done so. And I'm asking my colleague Catherine to put the link there so that you can do that at your leisure. But without further ado, let me please turn over the webinar to a very close TWP friend and colleague, Gareth Williams from the Policy Practice, whom I want to thank for all the amazing work he has done to bring together this first webinar on thinking politically about health systems resilience in the context of COVID-19. So over to you, Gareth, and very much looking forward to the discussion. Thank you.
Thank you, Alina, and welcome everyone. Great to see so many people here. So we're going to start this series of global webinars on a critical topic of the moment, the resilience of health systems in the face of COVID-19. Over the past 2 years of the pandemic, the resilience of health systems has been severely tested in nearly every country of the world. Countries that have had more resilient health systems have been able to save more lives from COVID-19 and have been able to maintain other vital functions. But we've also witnessed lots of distressing images of health systems that have not coped well precisely at the time when people need them most. So in this webinar, we're going to be asking the question of why some countries' health systems have proven to be more or less resilient in the face of COVID-19. Obviously, the impact of the pandemic has been highly variable between countries and over time. But stripping away these epidemiological differences, we can also see that there are important differences in the way that health systems are organized and how they operate in a political, economic, social, and cultural context. And it's these very important factors that also contribute to or undermine resilience. So that's why we think that the problem needs to be looked at through this lens of thinking and working politically. Of course, health systems are hugely complex with multiple different components that interact and take different forms and function differently depending on the context. So it's very difficult to generalize about resilience. What we'd like to suggest in this webinar that it is possible to improve our understanding by analyzing specific country cases. And this is the approach we're going to take by looking at 3 countries, which we've selected because of their different types and levels of resilience problem. The 3 countries are Nepal, Cameroon, and South Africa. Now, obviously, this is only 3 countries, and in an hour and a half, we'll only be scratching the surface of a huge subject of research and action. But I hope we'll at least be able to demonstrate that it's important to analyze health systems resilience through a thinking and working politically lens, to identify some of the critical explanatory factors and priorities for action. We have 3 really distinguished panelists from each of the countries, chosen because of their vast experience of how health systems work on the ground. So from Nepal, we've kindly been joined by Mahesh Sharma, who is the chair of the Virat Nepal Medical Trust and has several decades of experience as a health systems consultant and practitioner, as well as being active in civil society and having written extensively for international conferences and journals, particularly on the subject of HIV and AIDS. From Cameroon, we're delighted to welcome Professor Omar Nyaju, who's the country director for the FCDO-funded Tackling Deadly Diseases in Africa project. This is a 5-country project for which Omar is also the technical lead in charge of international health regulation and One Health. From South Africa, we have Dr. Tumelo Asahai, who is a senior researcher at the University of Cape Town, focusing on health systems research with a particular interest in community health workers, and previously worked for the as a technical advisor for the Health Systems Trust. And to help us discuss cross-cutting themes, we're very fortunate to have Dr. Del Sonia with us today from the University of Lund and the Karolinska Institute in Sweden. She's written and researched extensively on the topic of health resilience, and she is currently joining us from Zambia. I'll be asking the panelists 3 questions, which will take us up to the end of the hour, and then we'll move into a discussion with the audience. So please do post your questions in the chat box throughout the discussion, and we'll be selecting questions to put to the panelists in the final half hour. Please note that this discussion is being recorded and will be published online afterwards. We'll also be drafting a policy note summarizing and taking forward the discussion today. So let's dive straight in with the first question. I'd like to start by asking the 3 country panelists to give us a quick assessment of how resilient the health system has proven to be in their country. And we're looking at resilience from a broad perspective, referring to the ability of health systems to prepare for, to respond to cope with, to recover from, and to adapt to shocks, while at the same time providing high quality and equitably distributed health services. So how resilient was the health system in each of the 3 countries? Mahesh, let's hear from Nepal first of all. Mahesh, you're on mute.
Thank you, Gareth, for the nice introduction, and happy to see you all here. Okay, to your first question, first of all, I would like to start with a word of appreciation to all the health workers and the team in Nepal who did really manage the crisis. Although despite the initial confusion, worry, and lack of preparedness for this kind of pandemic, which is indicated by high cost of PCR tests, sudden lockdown without much preparation, death rates, etc., etc., which resulted into some kind of hotspots action in the beginning. But the health system in Nepal exhibited a very fair level of resilience, particularly in making the response plan fairly quickly, in setting up emergency response team, and setting up a command center. Beside that, the central government was also able to disburse additional budget fairly quickly to Ministry of Health and the provincial governments so that the response can be initiated and managed at the local level. But again, having said all this, the health system in general could not anticipate the magnitude of the damage. Probably this is the case for all over the world, that COVID could do, and the plan for essential medical supplies, particularly oxygens, PPE, and other supplies. Although the team in Ministry of Health quickly worked out and a projected plan for oxygen and other supplies required, there is no proper mechanism in place to acquire it. For example, funding, other kind of thing. The focus of whole preparedness was setting up isolation center at all levels, from top to a community level. Some centers were reasonably good facility, hygiene and sanitation and other basics, but most such centers were without much facility. After a while, many such centers remain vacant as people prefer to stay in home isolation. Now, again, talking about, despite all that, how quickly the health system returned back to its normal state of affairs. Again, it's a very tricky issue. What is the normal state? That's very difficult situation. But what I could say here is Nepal has been doing very well its mass vaccination campaign, including to the age group of 12 to 18, consequently, which has helped the recovering economy as well as daily walk of life. If put in the context of vaccine inequity across the world in the earlier stage, Nepal should be lauded for this accomplishment. This is largely due to high acceptance for vaccine in Nepal, and also due to the fact that existing practices and the past experiences for immunization in the country was already better. But again, what this has provided a kind of a great opportunity to learn something for the long run. So a number of critical learnings from COVID pandemic was internalized, particularly in preparing and upgrading the health infrastructure. This is well reflected in the plan and proposals submitted to the external development partners for funding. Some of the area were upgrading the laboratory services, including the availability of PCR tests, oxygen production plants in the peripheral hospital, increasing hospital bed capacity, and so on. And another learning that came out of this crisis was related to the shortage of health workers, which was very chronic in this part of the world, which was fairly properly reflected in approving additional position of health professional at all levels. So in a way, whole, I would summarize that the country seems to be recovering fairly well despite all these kind of difficulties. Thank you, Gareth.
Thanks very much, Mahesh. I think that really nicely illustrates how you can look at resilience at different stages in time. So you said there were problems before the pandemic regarding preparedness, when it hit, initial problems coping, but quite quickly a response that came in effectively, rapid recovery, rapid vaccinations, and also good to see those examples of learning and adaptation that you're already seeing as a result of what's happened. Let's have a look at what happened in Cameroon. Omar, could you give us the background on the pandemic and resilience in Cameroon?
Okay, thank you, Gareth, and thanks everyone for being part of this panel. It's really a pleasure to share some experience from Cameroon on this pandemic and how the health system, faced the pandemic. So I'll start by saying that contrary to other countries, and I would say really, we didn't have a terrible shock when I look at what happened in the US or in Europe. We didn't have a very terrible, I'll say, epidemic in Cameroon, at least for the first wave. But in the second wave, it started becoming very serious and really affecting the health system. So we would say that in Cameroon, we had 3 waves so far, but the second wave was the most important one and the one that really affected and showed, how fragile was the health system. I must start by saying that based on the information received from other countries, the country started to be preparing for the epidemic. So what they started doing, the health system started with having a response plan in place in case there was an epidemic. So that was really a good thing, using surveillance data, particularly from other countries, and evaluation of what happened in other places to put already a response plan in place, even long before we had the first case. So when the first case hit in Cameroon on March 13, we actually had to deploy the response plan, and then we actually realized that the response plan wasn't as easy to deploy as we thought on the paper. So, it started overwhelming the system with a lot of people, being sick, being confused, overloading and overcrowding hospital, being in fear. So several measures were taken by the government, and I will discuss it later on, very late. Some of the measures were taken so late. And what I would say, and it's a really big pity, that the big toll was on the health workers. So basically the doctors were the first people actually who were starting to feel the bad side of the epidemic, with a lot of death among the nurses and particularly the doctors. So with that, there was more fear on the system, and everybody started talking about IPC training, infection and prevention control. And so you see, when we have health workers starting to be the first affected, you see a system that becomes very fragile. But what was done now for that one was that the government started building trust again in the system. The people started trusting the system again, going back to the hospital, because even the hospital were not more used. They were feared as a place where people get infection, where people die. So I'll say that when we had on the leadership and governance part, we had a lot of engagement from the Public Health Emergency Operating Center. So that was the activation number 1 from the government. Say we activate the Public Health Emergency Operating Center, which thanks to Ebola was already set up before. And that could really help our system to become very resilient. And then based on that operationalization there, we had a very good surveillance that was already in place. We had to use the information that was available in different countries to actually prepare and effectively respond to the pandemic. And then finally, what was very difficult was service delivery in terms of maintaining quality of service. It's really hard to maintain quality of service because you have an overflow of people and you have very much staff not trained into the epidemic. So the good thing is that we had to prioritize in terms of what can we do first, and then everything turned out to be COVID. So all programs, including HIV, including vaccination, everything, that tuberculosis, because testing was done through the tuberculosis system, the whole PCR system, everything turned out to be only COVID. So I would say we coped pretty well, but at the expense of other diseases, other pathologies, but the system could become really resilient in the face of the epidemic, and the recovery was very hard for the second phase, but on the third wave, we could already see that things were becoming more and more normal. So I would say, thanks to the surveillance system in Cameroon, we're really able to cope with the system, and now we are getting back slowly to normal.
Thanks very much, Omar. And really interesting that you've raised these kind of knock-on impacts of the response to COVID on other parts of the health system. And I'm also very struck by you're reminding us that we're not just talking about the resilience of systems here, it's the resilience of people. and sadly, health workers were right in the front line in terms of the vulnerability to infection. Great. Well, let's move on to our final country, South Africa. Dr. Tumelo, please tell us what's happened there.
Thank you, Gareth, and thank you for having me today. It's a pleasure to share what the experience has been in South Africa. So South Africa was hit hard in all the waves of the infection in the rest of as compared to the rest of the continent. And as the president said yesterday, the response has been generally good compared to those other countries. So South Africa's health system could be generally described as resilient because since the start of the pandemic, it has been seen as really coping with the plans that were put in place. So South Africa has a National Institute for Communicable Diseases, which you call NICD, that has always provided world-class surveillance, epidemiology, and public health research and training to support the government's responses to communicable diseases threats such as malaria and recently COVID. In January 2020, after the infections in China and the other countries in Europe, the government activated the Emergency Operations Center, which among others included the NICD and the National Health Laboratories, to support the national public health response to COVID-19. So the first case in South Africa was detected on the 5th of March, 2020. And within about 2 weeks, the president declared a national state of disaster, banning international travel, closing schools and other things, and implemented a strict lockdown for 35 days, meaning people were bound to their homes. Many businesses had to close. And this was mainly to prepare the health system to deal with the expected rise in cases. This included mobilizing resources, PPE, human resources, and infrastructure. These measures slowed the rise in cases for this period. Subsequently, government instituted differentiated lockdown levels in line with infection rates, and the country has had 4 waves since of the infections. The first wave started when the strict lockdown was eased. Most provinces had already made provision of extra health workers and beds within the formal health system and field hospitals in the different municipalities. Measures were taken within the health system and other sectors in the early stages of the pandemic to protect the health sector. Hospitals were restricted to perform emergency surgeries only. And South Africa, with a high rate of alcohol-related road accidents and physical injuries, alcohol was banned to ease pressure on emergency and trauma units to make room for COVID-19 patients. Government needed to protect lives and livelihoods. As you know, it affects economy as well. And with the ruling political party committed to the cause as well, government worked to release funds towards the response. It is estimated that government allocated about 6% of the GDP to the country's GDP in 2020 to the pandemic. And government also provided grants for anyone over 18 who had no income or any kind of government grant, and businesses during the restrictions to ease the pressure. The health system got exposed during this response as the response was uneven across the country. An example is one province, Eastern Cape, that ran out of oxygen during the peaks of the waves, and many COVID positive people didn't make it to facilities as some hospitals were overwhelmed and ran out of beds during the second and the third wave. There were excess mortality of about 250,000 across 4 waves, followed, and there were also there were issues with turnaround times and things like that. So at the beginning of the rollout of the vaccines, there were issues around the acquiring of the vaccines. The first consignment that arrived, that was the AstraZeneca, was later rejected due to its research findings and the expiry dates. When the vaccination started, it was on a pilot project, and this was only for health workers, but eventually the vaccination program has been made universally accessible and free at point of use. To date, 42.17% of the adult population has been fully vaccinated. Some of the challenges faced related to corruption, particularly in the procurement of PPE, which overshadowed the achievements, integrity, and strengths of COVID-19 response in the provinces. And some have argued that there was a lack of proper consultation with stakeholders, like the alcohol industry. When the bans were instituted, the industry felt that they were not consulted. Religious groups were also not consulted. So there has been a big drop in utilization of health services such as TB, HIV, cervical cancer screening, and there were reports of maternal mortality rising to about 25% during this period. So there have been many positives, but there have been some weaknesses exposed in the health system. Thank you.
Thanks very much, Tumelo. So, I mean, we've seen from these three very interesting country examples that there are differences between the countries. Each has shown different levels and types of resilience. I think it's quite difficult to say if one country was more resilient than the other. We've seen different types of strengths and weaknesses at different points in the epidemic. Well, I'd now really like to shift attention to trying to explain these differences. So what are the main political, governance, and institutional factors that explain how resilient health systems prove to be in each country and why? So perhaps in the same order, Mahesh, would you like to explain what you saw in Nepal?
Thank you, Garrett. This is quite a tricky subject, actually, to talk about political and government institutional factors. Nonetheless, this is the very important factor. Without the governance is in right place, nothing seems to be happening. In Nepal context, Nepal recently moved to a federal system of governance only 5 years ago. So that made everything changed. The whole health system was changed from one particular system to 7 provinces. Therefore, it in a way reshuffled the whole health system, So that was a very critical issue to discuss here. So when we talk about the political leadership or political context, the context make things quite complicated at a certain point of time. Because the country was very used to have a one unitary system from Ministry of Health to down up to the community level. But when this structure was changed, there's quite a reshuffling happening in everything, including human resources and everything. So again, the issue here is, because of the political changes, the political leadership at all levels were at the learning phase. And everyone was working towards political stability. So for many, health has not been a priority at all. Therefore, the role played by the political leader also in the COVID context was very mixed. It's not only the system, the leadership also was trying to learn and cope, So there's a mixed response. Having said that, there are 1 or 2 very good examples. Some local political leaders proved to be very, very active and supportive in their community. They really advocated and strongly lobbied for additional support, for test and relief support. They even personally contacted the infected household to make sure that the support is available to them. So, it really made differences to the people who were really infected and locked down in the home. But such leadership was not very common anyway. So, again, despite the central level role, the provincial and local municipal governments took some initiative to augment the effort of health system by setting up holding centers, isolation centers, facilitating PCR tests, and also providing food and relief material to the poorer community. Also, the local procurement, as far as possible, for example, masks, sanitizers were also provided and locally purchased. And it also provided, the hospitals with some finance and some equipments, oxygen concentrator, etc., hospital bed, and so on. But all such move was often one-off event. rather than based on very, systematic planning, systematic data, and therefore it is inconsistent and with an ad hoc decision. But again, looking at the mandate for the health at the provincial and the municipal government, they are given a full mandate to plan and implement the health program. But due to the lack of experiences in taking the health-related decision, often low priority was accorded to the health sector in general. Shortage of health care cattle and lack of confusing communication to and from center was widely felt on rapid consultation. Nonetheless, the one important point I would like to share here is because of the existing rules and regulation, the much needed rapid recruitment of health workforce was not possible due to cumbersome rules and regulation. Also, the health worker was promised to be additional incentive, which was not executed quickly due to the delay in additional fund disbursement from the government. But here I must say some issue about international support very quickly before I end. The international actions particularly were disappointing, honestly, at the beginning when country was in dire need of basic supplies and oxygen, PPE, hospital beds, and everything. At the critical point when oxygen was very short supply, international assistance was not coming. Every country was busy handling their own problem. Even the closest neighbor, India, we would rely often, was consumed by its own crisis. Therefore, many countries and international charities started to bring in supplies later, even that also without much coordination with the government and assessing the need. Therefore, there's a lot of hotspot situation, but nonetheless, the political leadership struggled very hard to manage the situation. Thank you very much.
Thank you very much, Mahesh. I think that's a really fascinating example of how the broader governance changes that were going on in the country fundamentally affected the health system and its resilience. So thanks very much for sharing that with us. Omar, from Cameroon, what were the sort of key explanatory factors that shaped the resilience of the health system and the effectiveness of its response?
Okay, thank you, Garrett. I must start by pointing out on different aspects of the system. You have several factors that contributed to either the fragile or the good, outcome in terms of the health system. I will start with the political leadership, on this. I would say that in the beginning, we had a lukewarm commitment in the beginning, but that became very strong thereafter. So in the beginning, of the epidemic, I think they got the untimely decision. For instance, closing borders in Cameroon, we think that it came very late. We think that it became at the moment where it was supposed to be done like 2 or 3 days before. But the good thing is that the government quickly mobilized resources. The resources were really quickly mobilized. We really had the money at the time. The system had the money, was funded right on time because most resources were directed towards, response to the epidemic. And then there was a strong pressure following the barrier measure. So the politician had to really feel the burden on the confinement, on the restriction that followed thereafter, because there were no accompanying measure to those barrier measure, like strong accompanying measure, I would say. But I would say in the leadership and governance aspect of it, I think it was not bad. We had a multi-sectoral committee that was put in place, but the worst about it is that we had a presidential task force that took over the traditional, One Health platform, for instance, that was expecting to take over things. So we didn't see the traditional structure in place. We started seeing, more political or more high-level government task force that was ad hoc and but really didn't know the aspect about multi-sectoral coordination mechanism. So it was one of the things that was a big problem there, that the ad hoc committees started replacing the existing structures, and we didn't see the national One Health platform, for instance, working. One of the things also that was there is the other factor, the population factor. And one of the big things there was the lack of public trust. The government was not very much trusted by the population. There was low confidence in the government and the measures. People really didn't believe in the COVID in the beginning. They didn't believe even in the barrier measures. So with adding to the existing conflict in Cameroon, for instance, we have the Anglophone and Francophone conflict in the Northwest and Southwest region of the which are Anglophone compared to the Francophone, and the Boko Haram crisis in the up north, which usually affect very much the health system. I would say they didn't have a big issue there, but they contributed in the lack of trust in the government just because of the way the government has handled, replaced the anger there with the anger from the government, and really did very bad publicity and orders to the government. One of the things that I mentioned in terms of structure was the organizational structure. It was, in the beginning, it was centrally managed at the beginning, where everything was centrally at the Ministry of Public Health, managed there, or at the presidency. But the decentralization had come in place, and it came out very late. So the crisis response to the epidemic became decentralized much later on, and there was a poor coordination between the central and the local level. So the good thing that happened there is that we later had CSO, civil society organization, capacitated, and which really helped the resilience of the system. We had a lot of community health workers that were not engaged early in the COVID-19 response, but later on, even actually through the work of DIT, that Tackling Deadly Disease in Africa program, we work on impacting or on having the CSO, the civil society organization, capacitated to respond to the epidemic. Particularly, most of those CSO were used now during the COVAX, during the COVID-19 distribution. So another thing that really impacted a lot of on that response was also the lack of trust in the public, with the public having suspicion of funds mismanagement. And that actually, was a very bad thing, and an investigation actually is open into some suspicion of fund mismanagement in the COVID response. So one of the, to talk about the last thing, is the international support also that made the system to be resilient. But the first thing was the support from the WHO. At the beginning, I must confess that the WHO support was not very much appreciated, because they came in with the first 8 were cars. We have all this 4x4 came into the country as a support from the WHO, and people really, that contributed really into the lack of trust in the WHO and other people. But later on, they came in with really what were useful as oxygen and masks and all those things. So I would say the late implication of other technical and financial partners were very much appreciated. And then long-term, international support has been very helpful in building, the resilience of the health system in Cameroon. So I think the partners like TDAP, Tackling Deadly Disease in Africa program, actually worked a lot on COVAX hesitancy, and which was a very big challenge to our health system, the vaccine hesitancy. People didn't trust the vaccine. And I guess with that, our system became resilient. I would say a lot due to the work from the civil society organization, and also that the leadership now became responsive to the need of the people.
Thanks, Omar. That's really interesting. And I think what that case really illustrates is how the response to COVID itself created changes in the institutional and organizational structure of the health system. You mentioned the sort of centralization, the bypassing of the conventional structures in health security, and how that all changed for understandable reasons, as government and political leadership felt they needed to take control, but a whole lot of knock-on impacts from that. Let's hear lastly from South Africa again. Dr. Tumelo, how would you explain the aspects of resilience and weakness that you've explained to us from South Africa?
Thank you once more. So in the beginning, there were structures that were set up, some of which were called command councils. So there was one at national that was headed by the president at cabinet level. There was others at ministerial levels, provincial levels, and local levels that were primarily guided by science and evidence. And then there were policies that were enacted. One such policy was the National Disaster Management Act, as part of the response, and it's still in use. So what has happened is that the president became the face of government with regular updates, media updates, and presentations in terms of government responses, following advice and consultations with scientists and other relevant stakeholders. So the scientific bodies were very involved in the response, and they gave regular advice and consulted a lot with government. And this was just to guide the preparation, containment, and mitigation activities for the general health sector. But these were not without contestation when some of the measures decided through the, the Central Command Council that was led by the president were seen as arbitrary and not based on evidence. For instance, there was once a ban on smoking, on tobacco, and it was challenged in court, and the ban was removed. One other was the restriction on purchasing of clothing, and this was May, June, when winter started in South Africa, and this was also removed. So, as you would know, South Africa has a high burden of, had the highest burden of HIV, and this means that we have an established scientific expertise in the country. And this was rapidly repurposed for COVID-19 that conducted numerous research on the virus, such as genetic sequencing, evidenced by the quick detection of the Beta and Omicron variants. There was also a lot of public-private partnerships that developed and that were strengthened in the response to the public health sector, to the pandemic in the public health sector. So there was a joint public-private partnership fund, which was launched to raise money and contribute to specific needs like the PPE. Another example was the partnership that was used, that was the use of public and private laboratories for tests conducted in the public sector to increase capacity and turnaround time. And also with the highest burden of HIV, it means we have a network of health providers, including tens of thousands of community health workers experienced in conducting door-to-door activities or services in socially vulnerable communities. So government utilized these community health workers, which was about 30,000 of them, to trace and screen communities in high-risk areas to for people who were suspected of having COVID. So I'm just trying to see points that I can miss and just, okay, another one was that the Department of Health at national and provincial levels had communication strategies. So they embarked on a communication engagement, crafting science-based and language-appropriate messages related to COVID-19, and this was mainly for businesses and other government departments in relation to COVID-19. Another one was civil societies that contributed significantly to the response, and one such civil society group was the CANS. This was Community Action Network that started in Cape Town, which was formed by ordinary people, with a mix of backgrounds, from communities getting involved in a range of activities, providing health prevention messages and social reliefs, such as helping homeless people with blankets, soup kitchens, and things like that. They also assisted in contact tracing and organizing transportation for the sick in the communities. However, these networks were not utilized by the public sector because they don't work along the the way government works, the way public health works. But however, these networks were replicated across the country, across provinces. But unfortunately, where the need was great in the rural areas, these did not find fit. So yeah, those are just some of the things that happened in South Africa.
Thanks very much. So a huge number of different factors have come up in those three presentations. So I'm now going to give Del the challenging task of trying to pull some of that together and identify common themes.
Thank you, Gareth. I will do my best, but it's very nice to be here. So I think one of the things that's useful in this context is to think about the capacities that can help the systems govern resilience. So the capacities that the system has that govern its ability to adapt and to change. These capacities cut across a lot of the things that we've already heard about from our different panels, the different institutional and political factors. So two capacities that I would like to discuss are legitimacy, which we are familiar with, but essentially the capacity of the system to create a system that is trusted by the population and provides socially acceptable and contextually appropriate care. And then also uncertainty, or the system's ability to anticipate and cope with uncertainty through the actions and decisions of the individuals, groups, and networks within the system. So if we take these two capacities as examples, with uncertainty, we have seen there's pretty good evidence that strong and transparent leadership has been key to managing uncertainty during COVID. We've seen, with fast and particularly flexible, as a key word, coordination, and then clear roles and responsibilities for the individuals and groups in the system have really characterized a lot of the effective responses that we've seen, because they have supported decision-making while the situation has been continually changing over the last 2 years. However, I will say, I think that it gets trickier if we want to start talking about centralized versus decentralized systems, which has come up a little bit as a strategy for counteracting uncertainty. So I think in this case, the pandemic has actually raised more questions than it has answered. There's no real agreement, and we've heard a little bit about this from the other speakers about which organizational structure is best in terms of speed or efficiency or flexibility, particularly while responding to these prolonged national level shocks that are not regionally focused and are not short term. I think there are arguments on both sides. Some argue that less central oversight may have led to poor coordination and slower reactions. On the other side, decentralization can support, buffering capacity for resources, or let systems introduce measures quickly at a regional level when they're needed. Excuse me. One area that I think is important that is often not acknowledged is on the decision-making process for the COVID response. And I think this ties very closely to trust and a number of the issues that have been coming up here. So there seems to be, in this case, sort of with COVID in particular, a disconnect between governments and between health system responses, where political choices are really being made for public health purpose. So we see a lot of decisions becoming politicized, regardless of their scientific validity and regardless of their potential impacts on health. While policymakers have been under pressure to really implement responses and plans very quickly and react to new information. So a different example outside of these three contexts is in England, where the government dismantled the public health agency, Public Health England, following critique of the response, which some people perceived as sort of a scapegoat for the government's handling of the response. So I think that going forward, understanding the decision-making process in the health system and advocating for greater transparency in the decisions, why these decisions are being made, will be extremely important if you want to generate strategies for building resilience. Another quick example, because I know we're a little bit behind, is legitimacy. So we see something similar with the top-down approaches to COVID response in many countries, where there haven't been any mechanisms for bottom-up communication from the population. And I think that bottom-up, not just top-down, is extremely important, and neglecting to involve communities and civil society, as we were just hearing about, although that was an example of actually involving civil society, and not just passive recipients, but active participants in decisions around their own health and as important sources of knowledge for COVID, can lead to disempowerment and distrust in the health system and in the government, as has been alluded to by some of the other speakers. So I think going forward, it will be useful to know what effect these different engagement processes, if they existed, have had on the effectiveness and appropriateness of the different responses.
Thanks very much, Del. Some really interesting cross-cutting ideas there around trust, legitimacy, the centralization versus decentralization. We're starting to get questions on this coming up in the chat. There's a Q&A bubble that you can use at the bottom, or the chat function. We've got a few questions. Please could you use, in the next 10 or 15 minutes, put your questions in there, and we'll soon be moving on to the question and answer session. But I'd like to shift now from the thinking to the working politically and focus on what needs to be done to make health systems more resilient. So for the final question, I'd like to ask, what are the principal political and governance challenges that need to be addressed to make health systems more resilient in your country? What needs to be done differently and how? I'll start again with Mahesh. You've already alluded to some of the points, but if you could give us a quick summary of what you think needs to change in Nepal to make health systems more resilient, particularly at a political and institutional level.
Well, thank you. Well, this is also a kind of outsider perspective in a way, that I have one or 2 points just to highlight here. One point particularly is the local government played an important role in managing isolation center, facilitating access of people to the hospital, availability of PCR tests, providing additional resources, and engaging community to provide essential drugs like ART drugs for TB clients and the TB drugs, HIV and TB patients. So, local government plays a quite important role, but again, and gain very valuable experiences as well in managing the emergency. So therefore, now the local government now needs a strategic preparedness and response plan during the health emergencies such as COVID or other disaster to secure both technical and financial resources. That's one critical thing I would suggest needs to do. Next part is there's been a lot of protocols and guidelines developed at the center for the health emergency management. But those guidelines and manuals needs to be rolled out properly through series of training and follow-up and refreshing the health care personnel in addressing those parts. That's another part. And third part probably is, again, during this emergency, what is required is the human resources and the ability to procure things very quickly if needed. But again, due to the rules and regulation, such rapid procurement and the recruitment of human resources was not possible. So therefore, there must be a plan or procedure that can be activated only in emergency situation, so that whenever there's a need, the procurement of goods and supplies and recruitment of human resources possible to address the emergency in time. So I have only 3 suggestions to make here. Thank you.
That's perfect. Thanks very much, Mahesh. And I think, the last one chimes with, in all 3 countries, we've had references to corruption and procurement. And I think a real tension between being able to do this quickly in response to an emergency, while at the same time sticking to good practices around due diligence and the integrity of the process. So I think a real tension there, but it's something that definitely needs to be solved in future, as it's been a challenge across all 3 countries and other developed countries like the UK. Let's hear from Dr. Omar. What would be your 3 or 4 key things that you would like to change in order to strengthen health system resilience in Cameroon?
Thank you for that question. So I would think about the principal challenges in terms of empowering existing structures. We have like public emergency operations center. We have national One Health platform, which are capacitated, which are trained, and which is a structure that exists. And I think those structures should be empowered when we have those crises. I know it was a very serious one where in every country it was at the presidential level, but that is only the political one that cannot come and make decision, like real decision at the operational level. So I believe that by empowering those existing structures, like even just following the National Action Plan for Health Security is something that will really advance, in those kind of situations, because when you have those crises, every structure is put into bracket and new structure ad hoc emerge, it's really not a good way. I think I still believe in effective decentralization of the response. So we could really have an effective decentralization of the response will be really good thing. And those people at the decentralized level should be empowered too. You know, we need training, we need capacity building, IPC and everything. Those things will really make the system more resilient. Also, I think implicating civil society organization is a very good thing. We saw that with the COVAX, you know, with the hesitancy, when we had the civil society, you know, being implicated into the thing with the work of TDAP and all our partners, we could really see a change in the vaccination acceptance. So, and the last thing I will talk about is the supply chain. You know, this is something that's been neglected. We were thinking about everything but the service delivery, and sometimes we have the material, but we don't have the supply chain in place. Some places were lacking just the normal fridge or temperature to store some of those vaccines when they were present. So those are some of the challenges there. And I would think also that there were some positive things in this, you know, in these challenges. I would say it's a challenge, but some of those positive might be like public health emergency operations center, fully functional, but this time back to normal with those old structures being replaced with the new structures. So all in all, I would say we had a negative effect on other EPI vaccination, like the expanded program and immunization. That was very much affected because of the lack of trust in the COVAX, led to the lack of trust in all the vaccine, in the health services, hospital. I would think we should think about long-term political institutional support, you know, to those existing structures to fight the epidemic, to build the trust. The government should build the trust in the public and build accountability too. So accountability, again, should be one of the key things for a system to be resilient. Thank you.
Thanks, Omar. We were having some problems with the audio, but I think what you were saying is that, yeah, we, in moving on from the pandemic, a greater focus or refocusing on routine structures around health security, around health systems more generally, including a refocusing on routine immunization. So how to move back from the kind of emergency system that was put in place to a routine and long-term health security system. Thank you very much. Dr. Tumelo, from South Africa, what would be your 3 or 4 key things that you would like to strengthen in terms of health resilience and the politics and institutions behind it?
Thank you. So similarly, corruption has been an issue in South Africa. It really damaged the integrity of the response. But one other thing to talk about is that South Africa has a lot of has a challenge with. So the pandemic exposed a lot of inequities and inequalities in the South African system or in the South African society. And prior to the pandemic, the country had started with you know, introducing universal coverage for the country. But obviously, during the COVID period, this had to be suspended. But so I think the government needs to speed up that implementation of the NHI to improve the capacity and quality of the public sector. On the other hand, it has to regulate the pricing in the private sector that continues to be a parallel sector to the public sector, which is only accessible to the privileged minority of the population. So I think that was one thing that this is one thing that needs to be looked at to strengthen the resilience of the system, of the health system. Another one is the community health worker program. So we believe that community health workers are better placed to assist the health sector in tackling the high burden of disease that we have in the country through things like task shifting and given that we have high shortages of health workers, and by providing promotion and preventive services at community and household level. So there was a missed opportunity for community health worker for challenges in the program to be addressed we have issues around remuneration of community health workers. We have issues around integration of this cadre into the health system. We also have an issue about, what do they do and how they're implemented across provinces. So some of these things need to be addressed, and I think this can be of assistance in really making the system be resilient when faced like COVID-19, things like COVID-19. Thank you.
Thanks very much. Del, are you with us?
Oh, I'm very sorry. I think my internet connection just cut out for a moment.
Oh, okay. Are you okay to do a quick summing up?
Yes, sorry. Yes. Yeah, so I think I will focus on sort of two challenges that I see that for some things that are coming out from the presentations today. And I think one of them, which was already touched upon by Mahesh in Nepal quite well, and I'm very interested to hear more eventually about what he mentioned there, was but understanding the influence of multiple waves of COVID and getting governments and the health system to see health systems as systems that are actually capable of learning. So I mean, each new wave of COVID that is occurring essentially within a new system. So the system has changed and adapted new behaviors and structures since the first initial impact of COVID. So what worked during the first wave or the peak wave of the system, as is in the case of Cameroon, may not work now, or those strategies may no longer be necessary or important. So one quick, easy example of this that we've heard a little bit about from the different countries is the difficulties in sourcing and distributing resources, particularly at the start of the pandemic. So now when we're entering the third year of the pandemic, the health systems have started to learn from those initial experiences, and the challenges may be different. So I think going forward, it's really crucial for governments and actors in the system to understand what it is that the system has learned, and to understand that not all lessons from earlier waves will apply to following waves. I think we can take this idea a little bit further if we talk about the consequences of the pandemic. So resilient health systems are able to change and adapt. That's what makes them resilient. However, not all adaptation is positive. And we've heard a little bit about this from Cameroon. So where one adaptive approach was to sideline health system strengthening in favor of the COVID response. And I think in many cases that would be interpreted as a negative adaptation strategy. And as we just heard from Dr. Tumelo in South Africa, the pandemic has made some of the inequities in society much clearer. And one consequence of this may be, I can't predict the future, but maybe transformation of the system. So when the system sort of fundamentally restructures to reduce its risk to the same shock. So in this case, if the South Africa system is able to improve equity, the system will be less vulnerable to shocks like COVID in the future. And to quickly follow up on that, I think a second challenge, which has also come up, has the governance of the private sector in the health system. So as we've heard throughout this, private providers really play a major role in the ability of the system to coordinate a response and also to maintain routine health services. However, it is the public sector that is responsible for running the COVID response. And in a lot of cases, public sectors have been weakened by years or decades or very long periods of underinvestment, leading to sort of poorly regulated, poorly integrated services, less trust in the health system as a whole, and poorer coordination between the sectors. So we can also see from examples of systems that have strong oversight of the private sector that it's helped to do things like reduce competition over resources during COVID. So if we're talking about resilience as a whole, as a concept, we don't really know yet about how the private sector should be governed and regulated in ways to promote resilience. But I think a key point to take away from this is that there's often no distinction made between the governance of the two, with the assumption that what builds resilience in the public sector will also build resilience in the private sector and vice versa. So I do think that resilience capacities differ very greatly between these two sectors. And so I think particularly in systems with highly unregulated private sector. So I think an important area going forward is differentiating between the governance of the sectors and how this can help support resilience in the future.
Thank you very much, Del. Some really interesting points. So we've covered a huge amount of territory here. We're going to be getting some really interesting questions up in the chat. I see that there are several questions on the subject of trust. So I think let's start with that. So yeah, what one audience member has asked, what has enabled or undermined trust in the COVID context? And is it possible to regain trust once lost? Sam Bickersteth has asked whether it's possible for health systems to insulate themselves in contexts where there's generally low trust in government. Are there examples of health system accountability working in such contexts? And we have another similar question posted by anonymous attendee. What are the impacts of the damage to public trust from difficulties authorities revealed, not in their management of COVID, but in the full delivery and management of other health and non-health delivery obligations? So, I mean, we've heard quite a lot about this from the three countries. Omar in particular emphasized the problem of low trust in Cameroon. Was this also an issue in Nepal and South Africa? Which of our panelists would like to respond to these questions on how trust can be restored, how health systems can still function in a context of low trust? Mahesh, you just put your hand up.
Yeah, this is a very interesting question actually. One of the very important factors that damaged the credibility was corruption and lack of early decision-making capacity. So corruption is something we discuss whole. I mean, it's a very complex issue that probably we can't discuss in this short discussion. It needs more longer discussion on the corruption. But when it comes to quick decision making, again, we discussed having a new structure in place during emergency may not work or may have a different impact. So what happened in Nepal also, when the emergency was declared or identified, a central high-level COVID emergency management center was set up. COVID crisis management high-level committee was set up, chaired by Deputy Prime Minister, for example. So most of the decision is taken by that committee. So again, that structure initially was not there. So therefore, when the normal thing happened on the health, it's a Ministry of Health and the team would take a decision and implement it. So because of this, what you call it, COVID crisis center, every decision has to go through that center. So that delayed some of the decision. So that's one concern. And second thing is the whole purpose of that high-level body was to coordinate with other sector, including the private sector. So coordinating other sector means, okay, they were very effective in putting lockdown. All security personnel was mobilized. So that's one thing. But again, that's not the issue here. The issue is how they managed it. Lockdown is not the answer. It has proved that lockdown has not been an answer. But again, there was an interest of making lockdown longer or regularly. So again, that also affected the credibility. So people started not kind of, avoiding the rules set up during the lockdown situation. They found all the way to break it down, all the movement, everything. So, so that the government needs to be very vigilant of people's response and then change accordingly and managing. So that was lacking. And of course, because it is lacking largely because that, the decision-taking authority from health has moved to non-health team at the high level. So therefore, that it's not only at the top level, it happened at the provincial level also. So therefore, when the health has never been a priority for many top leaders, then suddenly getting them into decision-making process would affect it. So despite that, some of the decision taken was quite good. We should appreciate that some of the decision. They were able to identify quickly the additional resources that is required. So that's one very good decision. And they were able to negotiate the vaccine fairly quickly to international community, even bilateral community vaccine from, so that's also one good point. So, that should be appreciated. So my final concern is, getting back to the credible issue is ability to take quick decision. So therefore, they must try hard to see how best they can take a decision, sort of, not try to bring the political agenda in front while making the decision. Thank you.
Thanks very much, Mahesh. I think you've really nicely summarized the importance of credibility and how difficult it is to earn that by taking the right decisions at the right time in a fast-moving context, and yeah, how easily trust and credibility is lost. Del, you've raised your hand.
Yes, I wanted to add on because I think Mahesh is making a really important point in his mention about what do you do when you have low trust. And I think a lot of the times when we talk about trust, we sort of follow the rational assumption that if people trust the health system in normal times, they will trust it during critical times when there is a shock like COVID. And I don't think that that is necessarily true. I think that the trust differs depending on the situation that is ongoing. So I think a lot of work around resilience has been about how do we sort of build trust before a shock happens. But I think we need to understand, as Mahesh was pointing out, what happens to trust during that actual shock, and then how can the health system adapt to those lower levels of trust? And I think that that's something that has been missing a bit in the COVID response. There has been this assumption that we will react in the same way that we have before that has built trust, when that may not actually be the solution, and we have to find new ways to actually respond to those lower levels of trust.
Thanks very much. Clearly this question of trust, I think it's come out extremely strongly as a kind of critical determinant of the resilience of the system. And of course, it's not just the health sector, it's the behavior of politicians in all of the non-health sectors or all of the other broader public health measures that are tied into the COVID response that affect that. So a hugely complicated and interesting set of issues. Sue Kim has just asked whether there are differences between levels of trust between the public and private service providers. I expect there'll be a complex set of differences between countries there as well. But let's move on to another question from Kate Gooding. On the point from Cameroon about creating new structures or strengthening existing fora, she'd be interested to know how this worked in other countries. To what extent did the coordination of the COVID response take place through existing structures, or were new structures created? And what led to decisions on which structures to use? I think this is a really pertinent question because, yeah, I mean, we've seen from the Cameroon case that there are concerns about how sort of new structures are imposed in a top-down way, perhaps undermining routine structures and long-term resilience. But at the same time, we can perhaps understand why leadership felt they needed to get a grip and be seen to be doing something precisely for this problem of credibility and trust. How did this play out in the other countries? Mahesh, you've alluded to it a bit, and particularly with the sort of chaos around the decentralization and uncertainty about which structures to use. But would you say the response in Nepal was mainly through existing structures, or were new structures reimposed on top of that?
I mean, it is largely using the old structure because the same health cadre was all over, which is to be accountable to the central ministry. Later on, change their accountability to provincial and local municipal governments. So largely it was through the existing structure. But again, the question here is their reporting channel and decision-making process has been changed. Previously, it used to be the central ministry making decision for the whole health system. Now it cannot do that. There's a provincial authority who do the health for their particular province. So therefore, while the health information, health technical guidelines came from Ministry of Health. The actual decision has to be at the provincial level. So therefore, this kind of a new structure was in a way, it supported in some aspect, but it was not good support in one aspect. So therefore, this needs to be very critical review. How such additional structure or new structure can be activated fairly quickly in terms of emergency, how they prepare themselves in terms of responding to the need of the people during the emergency. So this is fairly new structure. So it's very difficult to say at this stage because it's only the 5 year, or honestly, it's only 3 to 5 years, the structure is in place. Therefore, it's very difficult to assess at this point whether those structures really were good or were not very good. So, but again, there's a mixed response from different groups. So I'll just say this at this moment.
Thanks very much, Mahesh. And then Tumelo, in South Africa, you mentioned the government quickly activated the Emergency Operations Center. I mean, was this the regular structure that is meant to be created during a pandemic, or was this a kind of hurried, rushed new structure that was imposed on top of what was already there? How did it play out in South Africa?
So this is a planned structure that is an emergency, that is planned for emergency situations like this one. So it was just the NICD and the National Health Laboratories. It has been there, but they always work together. It was just a formalized way of responding to the pandemic.
Okay, that's really interesting to hear. So those kind of planned existing structures were used, whereas we heard in Cameroon that they were largely kind of bypassed. Perhaps, Omar, could you sort of tell us a bit more about your concerns about this and the extent to which some of the existing structures in the health security system, the National One Health platform, were bypassed? Do you see this as particularly worrying, or do you see it as a normal response to an emergency?
I'll start by saying that
Sorry, Omar, we're having a difficulty with the audio.
Okay, can you hear me now?
Yes, perhaps try turning the video off.
Okay, so let me know if not, I can change my connection to a different one. Can you hear me?
Yes, I can, but perhaps turn your video off to preserve bandwidth. Okay.
So I was saying that, is that better?
Yes, much better.
Okay, so I was saying that in Cameroon, like in many other countries, everything went up to the very high level, at the presidency level, at presidential level. So the thing is that when it comes at the presidential level, it becomes a political decision instead of operational decision. So they will just give instruction on how things should be done. Like, for instance, I remember one decision that was very hasty, like you have to close borders, and then at the next minute, all flight on the, everybody was flying, all flight were turned over back to the country, even the one that were ready to land. These are political decisions that are very difficult to implement. And we have a lot of people, including Cameroonians, stranded outside the country who were just 2 minutes away from landing. So that's just showing that, for instance, when they wanted to create another structure that was a national program to fight against COVID in Cameroon. And I was just happy to hear that the WHO just told them, this is not necessary. We have an existing national action plan for health security. Just implement NAPs, just implement your NAPs, and then you'll be fine, and that's how, we had the balance of power there. So we know that in those kind of situations, we have a multi-sectoral collaboration mechanism that would take over. We didn't see any multi-sectoral there. And that's the problem with when the political aspect takes over, then they have a top-bottom decision where they just say, you guys supply hospital, they create new structure, they create a hospital section and everything, but operationalizing, working with data, working with data and everything, because the new structure, like we call it a presidential trust fund, they're bound to disappear, and then we'll come back to those old structure, but unluckily it's COVID like an epidemic.
Thanks very much, Omar. I think that's a very clear point, despite some of the challenges with the audio about the importance of using structures that are already there and continuing to make the argument for that. I think we've got time for just one more question, perhaps a positive one, from Nadim Hassan. To what extent have policy windows for prioritizing and strengthening health systems meaningfully opened or expanded due to the pandemic in your countries? Or to what extent are you essentially back to where you were before the pandemic on this front in political reality rather than rhetoric? So we've heard different messages, perhaps a more positive assessment from South Africa that the inequalities that were revealed by the pandemic have led to renewed focus on universal health coverage and national health insurance. From the other countries, yeah, Omar, I mean, you've been saying that perhaps there is a renewed focus on existing structures like the National Action Plan on health security. But yeah, who would like to answer this million-dollar question of whether COVID itself has created opportunities for correcting problems in health systems or readdressing imbalances? It's a very tricky one, probably requiring a crystal ball and maybe a lot of optimism, but who'd like to volunteer to address that one?
I'll try.
Go ahead, Omar.
No, I would try to, to read to the crystal ball. So I would say that I would think that overall, it's an assessment, overall, I think the epidemic was, an advantage in terms of, helping the health system. We had a lot of people pouring in terms of international aid. We have a lot of government understanding, for instance, the role of civil society organization thanks to COVID. We have a lot of a positive effect from the communication plan. We have a government that came in with a good communication plan, but that was not well deployed. So I think in terms of, if we leave aside the ad hoc committees and institutional structure, I think that with a lot of lesson learned, there was a lot of lesson learned from the COVID response. Even simple IPC training, will be something that we learn, that the people that are there to treat will be the first people who can die from the infection. So there were a lot of lessons learned, a lot of advantages in responding to the epidemic. And I think the political the political leadership learned a lot about accountability. They learned a lot about trust, and they learned that we have to leave the practical things, the epidemiology or the public health aspect, to specialists. And I think that learning alone is a good thing. Over.
Thanks very much, Omar. Mahesh.
Well, I just quickly want to add to Omar. Basically, important learning was, the health infrastructure really needs to be in place. Whatever emergency is there to address it. So government really planned a health infrastructure, to expand it up to the peripheral or even municipal level. So that's one important part. And in that government plan, there's many international assistance positively supporting it. So that's one important kind of lesson which will contribute in the long term. Second aspect I can see is, as Omar also pointed out, this communication and information is really important. Lots of misinformation, wrong information passing through internets and everything. So the government started a kind of everyday press briefing at the one set time. So that was very popular program. Everyone was listening to the government press briefing kind of thing. So hopefully that is a good lesson and the government can continue that. for any emergency or important aspect to publicly share it as quickly as possible, as open as possible. So that's also another thing. Next part is, as I mentioned earlier also, that there's a lot of guidelines and prepared for the health emergency. The health emergency center was put in place during the earthquake in 75. So, the structure was there. So, immediately activating that requires regular kind of a drill, if you like. If they do the drill regularly, they can act in the emergency. So that's also one realization. To make it more effective, such existing structure needs more drill and practices regularly. Just to say that. Thank you.
Thank you very much. And Del, would you like to have the last word on this one?
Yes, just very briefly, just to follow on from Mahesh and Omar's points on learning, which I talked about earlier, and I think it is really important. And then also in the chat, there's another comment from Lucy Gilson that touches on learning, which is what is it that actually enables learning? And I think it is very important to not underestimate the power of the relationships and the interactions among people within the health system. That, you can put the best policy in place, but without understanding what enables individuals and groups to make decisions or act in the ways that they should and that we want them to, it doesn't, just because the policy is there doesn't mean that they will follow it. And I think sort of that emphasizing those relationships and that understanding of power within the health system, I think will be very important going forward.
Thanks very much. And thanks to the audience for the excellent questions. I'm sorry we haven't had a chance to answer all of them, but we have noted them all down and we will be using them as we're thinking about developing the policy brief as a follow-up to this webinar. So it's obviously very difficult to sum up such a rich and wide-ranging discussion. But I'd like to ask each panelist if they could just give us one or two key points, some key insights or recommendations coming out of today's discussion that they feel are particularly important. So I'll reverse the order this time, and perhaps Del, you could start us off.
Sure. So I think I've made a number of key points already, but I think two things to take away from this are that first is to try to that we are still trying to understand what actually works in what context to build resilience. So it's not a one-size-fits-all approach, and I think that has been very clear from the conversations here today. And we also have very limited empirical knowledge on what strategies are actually useful and what strategies are useful in the long term, as we've also been discussing. So I think it's worth repeating, as we have seen, that context has to be understood if you want to understand the resilience of the health system. And then a second point is that, as we were just talking about, we don't yet know what the long-term consequences of the response to COVID will be. It may be that some strategies and actions that were implemented will have positive long-term consequences on health, well-being, and the system's performance. And I think it will be important to sort of keep track of those changes over time and really understand, so that in the future we have this sort of history of what it is that has happened and which adaptations have been beneficial in reducing risks to the system. And then we might be able to be well on our way to understanding what it is in a specific context that builds resilience.
Thank you very much. I think you've neatly set out a 30-year research agenda there. Thanks very much. Dr. Tumelo.
Thank you. I think one is about trust. And I think one thing that comes across for me is that, and especially in the context of South Africa, the trust among society, among people, is just not in the health system, but goes beyond the health system, but it's generally the service delivery from government side. So in fixing that, I think that will be able to build trust in the health system, and also speeding up the introduction of the universal coverage and proper implementation of that will also build trust in communities, because or across the population, because quality will be better, capacity will be better. Another one is, decisions were taken and implemented as and when things were happening. It was a moving car. Nobody knew whether it was a good decision or not. So I think there's a lot of lessons to be learned. There were a lot of good things that came out. There were a lot of failures that happened along the way, but it's a time to reflect back and say what could have been done better and what could be sustained and taken further. Thank you.
Thank you very much, Tumelo. I think a very realistic assessment of the challenge. Omar, a final couple of points.
Yes, I think I will put in the system, I would think that there's another pillar now in the system, which is actually the population and the population trust. That's very important in affecting, health system. We think about political infrastructure, governance, surveillance, but we always think about the beneficiary that are actually a big pillar into that. And if there's no trust in them, if the government doesn't build that trust, everything they do is built to will fail. And that we can see that with the COVAX. All of us know scientists that it's a good thing, but when there's no trust, the uptake will be very low. That's one of the things that I take as a lesson, is that the population itself, the beneficiary, are a very big pillar part of the system for health system resilience. And if there's no trust there, if they cannot build any trust, I don't think things will be bound to fail. Another big lesson there is, like we said already, with COVID, we are still learning. And then if the government actually can learn from the COVID instead of we, the scientists, learning, we need a lot of research there. Everything now is still empirical. We are thinking about all those things as affecting our system, but it's still very empirical. And I think there's an opportunity there for research, for operational research, to enter into play now and start looking at some of those factors, some of those evidences, some of those, things that might affect system health-wide. Because I would think that some countries, actually low and middle income countries, actually were more resilient than some of the Western or developed countries. And we should learn from also the less developed countries, low and middle income countries, how some of this resiliency, came about. And I guess because we had several crises, learning from that will be important for the future.
Thank you very much, Omar. Some very salient points. And let's finish with Mahesh from Nepal.
Thank you. I think I just wanted to say 2 points, but it's all interrelated. One is health has not been a priority in resource allocation in many lower income countries. Health is always either it's a third or fourth priority. All the development means infrastructure, road, building, bridges, blah, blah, blah. But the software part, we call it, receive less attention. So definitely there's increased attention in resource allocation is one important aspect. And another aspect is because it's related that many lower middle income countries are somehow dependent on external resources for the health services also. But COVID had proved that that dependency sometimes is not very good. It's not always available, that dependency. In a normal situation, it works, but in emergency, the external assistance sometimes doesn't work. And it didn't work, honestly, at the beginning. Therefore, a country has to kind of think of their own resources, their own capacity, their own ability. Although external resources is required, no doubt, but not in the critical situation. For the critical situation, there has to be internal mechanism to address it. Thank you.
Thank you. A very realistic ending point, and that's why we've taken a national focus on health systems resilience today. But of course, there is the larger debate about whether international assistance was helpful or unhelpful. And of course, resilience is a global phenomenon. As we've seen, the disease doesn't respect frontiers, and one country's resilience will affect another. So let's wrap up quickly. We'll be beyond time. I'd like to thank all of our 4 panelists for their really interesting and thoughtful contributions. I hope you've enjoyed the discussion, and that clearly we've only scratched the surface of 3 countries. We've raised a lot of issues. We've probably asked more questions than we can answer, but I hope we've made the point that it's helpful to look at COVID-19 response and resilience through a thinking and working politically lens. And of course, this discussion will be taken forward in our policy note, but also over the course of the year. In November, we'll have the Global Symposium on Health Systems Research, which takes an overtly political theme, where I'm sure a lot of these issues will be discussed further. So thank you very much, everyone. I've really enjoyed it. It's been a fascinating discussion, and look forward to the next in the series of the global webinars. Thank you very much.
Thank you. Thank you very much.
Thank you very much for having
Thank
us.
you.
Thank you so much, Gareth, and everybody. Have a
Thank
good
you.
rest of the day. Bye-bye.
Bye.
Bye-bye.